Welcome back. Aha, I am live. So we are bringing together our next esteemed panel, but let me, in the meantime, welcome you all back from what I imagine were really engaging and interesting breakout sessions, as well as a networking lunch that seemed to me to be just a wonderful opportunity for people to connect. So really glad to have you all here. Again, I want to encourage people to find their seats and settle in for what has been billed as a fireside chat, but honestly, it looks more like a fernside chat to me, but we will make do with the props that we have. We are now going to have a conversation with health leaders that will be facilitated by the indomitable Bobby Wunsch, for whom neither a small injury nor other obligations could keep her away. Bobby is the founder and partner of Pacific Health Consulting Group, healthcare management and consultancy that specializes in working with the safety net and its providers throughout California. She has provided consultation on a lot of issues known to folks in this room, including children's health initiatives, the development and implementation of locally managed Medi-Cal managed care plans, and she has facilitated many state and community stakeholder engagement efforts, including, for example, the COVID-19 pandemic vaccine advisory committee, and many others. Bobby is the perfect person to convene this conversation, and Bobby, please take it away.
Well, hi, everyone. You are lucky to have stayed to the end of the conference because the best is yet to come with our panel and then our closing speaker. So let me introduce to you people that you already know. Our new CEO of Covered California, Jessica Altman, and this is Jessica's first ITUP conference. So it's so great that she's here and that you're all here in person to see her. And of course, our DHCS director, Michelle Boss, who's been to many an ITUP conference, and so she's a pro. We're going to spend about 40 minutes together, and the last 10 or 12 minutes, we're going to open it up to questions from all of you. So you'll see the mic in the middle of the room, and when we get ready for questions, we'll just ask you to come to the mic and introduce yourselves, and make sure to ask really tough and insightful questions for our two great speakers here. So without further ado, we're just going to jump right into some questions that I've prepared for Jessica and Michelle. So let's get started with kind of reflecting back on the last year's accomplishments at Covered California and DHCS. What are you most proud of? And what do you see as the biggest milestones that both organizations have achieved in the last year? Michelle, do you want to start? Since Jessica has only been here 10 months, we're going to give her the benefit of hearing from Michelle first.
Sure. So maybe I'll start with some of our coverage expansion. Very, very excited to build off of California's choice to expand Medi-Cal, ACA, the optional expansion coverage, really, and then continuing with that coverage for all with children back in May of 2016. As of December, 142,000 children are eligible because of that expansion. And then January 1, 2020, the young adults, and we have 120,000 individuals eligible because of that expansion. And then this May, we expanded to older adults, and as of December, about 310,000 individuals are eligible for Medi-Cal, or enrolled in Medi-Cal because of those expansions. And then, as you all know, we are working hard to implement full coverage expansion for the remaining 26 to 49-year-olds, effective January 1, 2024, for about another 700,000 members. So that really brings us to about 1.3 million members really as a result of these expansions. And, the Medi-Cal program providing that coordinated care of all benefits, both physical, mental health, substance use, long-term care, dental benefits for all these individuals. As our communities are better and individuals are better, we really have these thriving communities. So very excited about that. In addition, as you all know, 2022 brought us CalAIM, very, very excited really how we break down the walls of healthcare, really going beyond the doctor's offices, hospitals, and clinics to see what are the factors that drive an individual's health, some of those social drivers of care such as housing, food insecurity, home modifications, et cetera. So very excited about really what CalAIM is bringing us. Lots of work to do to build out these benefits and these networks in the community, but very excited about CalAIM for 2022.
Well, first of all, hello, everyone. I'm so excited to be here at my first ITEP conference, certainly not your first ITEP conference, but also I'm just a privilege to be a part of this community in this state that is so collectively committed to increasing coverage and access, and it's been a wonderful 10 months, but I'm looking forward to many more months working with all of you. We're going to talk a little bit more about this later, but I just finished Covered California's 10th open enrollment period, and the team, we all just had a great open enrollment, but really an opportunity also to celebrate what we've done, not just this year, but over 10 years, over the full existence of Covered California, over the impact that the Affordable Care Act, both through Covered California and through the Medi-Cal expansion, has had in California. And I think it's a really great grounding for all of the conversations that we're going to have, or you have had all day today and will have throughout today, which is, we've reached record low uninsured in California in the midst of the pandemic. Covered California is coming off of, we're still waiting on crunching final numbers for this year, but last year, the highest enrollment that we have seen at over 1.7 million Californians enrolled. And because of pandemic policy that not only drove enrollment in our programs, but we are also bringing the greatest level of affordability that we have ever brought because of the American Rescue Plan, because of the Inflation Reduction Act, then extending those advancements into future years. And so it's incredible to hit a 10-year milestone at any point, but to hit a 10-year milestone also at this time when we're really delivering in the best way that we have thus far is very exciting. And then at the same time, turning that corner and knowing that we still have work to do and what that looks like. But I think the other thing just to celebrate is the way California has led the way in making that happen. So much of what I just talked about is built on California's commitment to expanding coverage in every corner of the state. We have led the way in outreach, in education, in working with our enrollment partners, our agents, our community partners across the state. And today we have 95% of Californians live within 15 minutes of a Covered California storefront that can help them enroll. And in a state this size, and believe me, I have been in every corner of it this open enrollment period, that's an incredibly impressive outcome. The American Rescue Plan followed on the California state subsidies that again put California at the forefront of leading affordability policy and driving the nation to do bigger and to do better because we showed that it could be done. And finally, I just want to say it's so great to be here in a time when we have an administration in D.C. that is also rowing in the same direction. Finally, 10 years later this year, we saw the fix to the family glitch come into, yes, thank you for those cheers, just a policy that has held back subsidies from people who should have had them to begin with for 10 years, and something we're incredibly excited to deliver. So, affordability, access at the highest it's ever been, but also a lot more ahead, and we're excited to do that.
Great, thank you. So I think everyone in the room is happy about the unwinding of the public health emergency and very nervous about the end of continuous coverage for Medi-Cal. And I think both of you have a perspective on this issue. But I think with redeterminations set to begin, as we heard from Kathy Senderling earlier this morning, it would be great to hear, Michelle, starting with you, about how the department will really engage local stakeholders and partners, providers, community-based organizations, community health workers, to help members maintain their coverage and not lose it. And then I know, Jessica, there's such an interlink there with Covered California. It'd be great to hear your perspective on this as well.
So this is definitely top of mind at DHCS. We're about 15.4 million Medi-Cal members. And we know that through the redetermination process, many individuals will lose Medi-Cal coverage and hopefully transition to, are already receiving employer-sponsored coverage, Medicare, or through Covered California. And our whole goal throughout this process that we've been planning for almost a year now is really to ensure that our members know that they need to take action, that they need to, complete their renewal process. We've taken advantage of all the different federal flexibilities that we've been granted with regard to kind of ex parte, streamlining some of the information with regard to asset and income information, really doing all we can to ensure a smooth process for our members. Back in April of 2022, we launched our Coverage Ambassadors program, and we have about 1,700 individuals and provider groups signed up really to help spread the word. We have toolkits in multilingual, our threshold languages, really kind of what members need to do to take action and really raising awareness about the redeterminations are starting again. And this week we will be launching a public information campaign, so commercials, radio, billboards, et cetera, really all about the renewal process and raising awareness and then taking action, kind of two phases to this engagement. This is a really important partnership we have with Covered California as well to ensure that our members know the necessary steps that they need to take.
Maybe you could just add a little bit more on what else local partners can do to aid in this process.
So if you haven't signed up for Coverage Ambassadors, please sign up for this program. It's available on our website, and really we have toolkits available, flyers, et cetera. We've been doing a listening tour throughout the state and really wanting to make sure folks take advantage of these tools so that they can spread the word. We have thousands of providers, thousands of community-based organizations that we work with, and the more we can get the message to our members, the better we all will be in terms of ensuring continuous coverage.
Great. Jessica, what are your thoughts on how Covered California can support this effort and your role in all of this?
Yeah. So I think all of us go into this, right, with the collective goal of keeping as many Californians covered as we can as we go through this process. And that means, first and foremost, keeping anyone on Medi-Cal who is still eligible for Medi-Cal and supporting them through that process. It also is going to mean that there will be individuals and families who are no longer eligible, whose incomes have changed, and who will need to transition to other coverage. Many of them will have employer coverage, or maybe they've turned 65 and are on Medicare, or whatever that is. But we also know that Covered California is going to be where many of them look for coverage. And it's a great time to be doing that, because with the American Rescue Plan, a lot of those transitioning Californians will be in the 2/3 of people we covered today who can find a health plan on Covered California for a cost of $10 or less per month. And so we really have such an important opportunity to keep people covered. And California, as usual, leading the way, thinking ahead, actually passed a piece of legislation, Senate Bill 260, thanks to the leadership of so many represented in this room, that enables Covered California to seamlessly, to automatically enroll individuals that are transitioning off of Medi-Cal. And really what that is trying to do, what we are aiming to do in implementing that, is to do as much of the work for these consumers as we can, rather than making them do all the work, starting over, filling out the application, navigating through the whole process. And what that will look like in practice is when someone transitions off of Medi-Cal, comes over to Covered California, we're going to say, hey, we have all your information. Here's the lowest cost silver plan in your area. Click yes. As easy as it can possibly be. Many of those people will have a $0 premium and just have to say yes. Others will have to pay the first month's premium to really enact that. But to make that process as simple as possible, to wrap around that all of the support services, whether you want to be on the phone, whether you want to do it through our chatbot, whether you want to be working with an enrollment partner who has worked with you before and will be notified when you're going through this process, whether you want to do it in a language other than English, really how can we support that transition in as many ways as possible. So we've been ready since last July, because that was the first time we thought we might be starting. But we've certainly, with a little bit more time, really been able to round out our partnership, not just with DHCS, but with so many of the on-the-ground partners to get ready for what we believe is this really important role that we have in connecting Californians to continued coverage through Covered California.
Great. I just wonder, as we dig a little deeper into this issue about enrollment and keeping people covered wherever it's most appropriate, in both programs there are remaining barriers to getting coverage. And I wonder, Jessica, maybe if you could start, what other insights have you gained in your last 10 months here that help you better understand what those barriers are, and perhaps how our audience here can help push through those barriers?
Yeah. So it's always important when we talk about the incredible progress we made to recognize we are not done, that there are still Californians who are going without insurance. I think there's been incredible leadership, and there are ongoing important conversations, in particular about the role that immigration status plays in that, and we're looking forward to the discussion about how Covered California can play a role in that is live and happening now. But at the end of the day, we also know right now, even without policy changes for Covered California or further ones for Medi-Cal, there are over 1 million Californians who are going without health coverage who are eligible for financial assistance either through Covered California or through Medi-Cal. And we estimate over half of those, so over 500,000 Californians, can find coverage for $0, either through Covered California or Medi-Cal. And so, that says we know cost has been a barrier, is a barrier in many cases to coverage, can be to care, but there are also Californians where that is not the barrier because they can find coverage for $0 if we can get them there. And, one of the things I've continued to say through open enrollment is the better we do, the harder it gets. When we started this 10 years ago, there were people lining up around the corner waiting to get in, and all of those people are covered today. And so it's going to take the harder work, the deeper work of really being community-centered, community-focused, and recognizing that the barriers for one person and one family and one group of people are not the same barriers for another person and another family and another group of people. This open enrollment period, I really took the time as I traveled the state to meet with communities, to hear from our enrollment partners, from local providers, from local enrollees about what those barriers are. And it isn't the same in LA from Eureka, and it isn't the same for the Korean community in LA than it is for the Latino community in LA. And so I think we're really excited to deepen that work, to build on the incredible foundation of outreach at Covered California as we head into this next phase of continuing to get people covered.
And maybe to build on that, last Friday I was at UC Merced. They released a farm worker study, and one of the kind of just hearing the experiences of the farm workers and the consumer advocates at that convening was really kind of to Jessica's point of different strategies to reach different populations. So whether it's ethnic media, whether it's really taking advantage of the community health worker benefit in Medi-Cal now to kind of, even if someone's enrolled, even just that they're eligible to all these preventive services, and really using these opportunities to reach communities in different ways, not just the traditional kind of, the normal ways that we have been in the past, how we think about the different strategies for the different communities that now will be eligible for Medi-Cal, and really that these are kind of their rights or their tools to getting better care.
Great. So much to do in this area. So much to do in another area, mental and behavioral health. And this is such a huge priority for the governor, and certainly I think for all of us, in terms of making sure that residents of the state have access to behavioral health services. What are you all doing at Covered California and at DHCS to really move all of the behavioral health initiatives forward and improve access to these essential services? Michelle, would you like to start?
Sure. I would start by saying there are many, many initiatives underway at DHCS, and we need a little bit of patience and grace because many of these initiatives will take time to kind of go to full scale. I'll start with CalAIM, which we just talked about, started in 2022, and some key behavioral health policies that have been implemented. First, I'll speak to really now behavioral health services are available without a diagnosis during the assessment period. We've streamlined eligibility for children in the child welfare system, justice-involved youth, to access to specialty mental health services. We have our no wrong door policy, so where an individual shows up, they can get the care they need instead of being shuffled between delivery systems. One of the other things that I think are really excited about is the adding of the peer support benefit, really recognizing trusted partners in the community, and really how do we build out our workforce so that we can make room for our clinical workforce to maybe focus on more the clinically intensive work and use our extending workforce such as peers, community health workers to really do that prevention, outreach, and education piece. We've launched the contingency management pilot program this January. So really taking advantage of this as evidence-based practice. Can't go without mentioning the Children and Youth Behavioral Health Initiative that's part of the California's Master Plan for Kids' Mental Health, and really the opportunities with our virtual platform that will go live in January of 2024, really thinking about how we can use virtual tools to do prevention, to really engage children and youth in their self-care and take advantage of the opportunities of peer supports, groups, et cetera, so that we provide other opportunities to intervene with our children and youth. As part of the initiative, also the fee schedule. And I know some of this is very wonky, but it really is trying to drive, where children are at schools and taking advantage of providing school-based services both in the Medi-Cal program and on the commercial side, and really trying to streamline that for schools so that they can provide services in a really efficient manner where the children are. We also have the Behavioral Health Infrastructure Continuum. This is $2.2 billion to build out our infrastructure for behavioral health services. So from wellness centers to inpatient psychiatric care, really we've launched 4 rounds of this, and 1 round focused on children and youth. But really, what do we need in the state to build out this capacity for services across the state? Some of the other important pieces I will just quickly mention. The launch of the mobile crisis benefit as well, really providing services to where individuals need the care that they need. And then all of this building on, we will be launching, or we're in the process of launching and designing our California Behavioral Health Community-Based Continuum Waiver. We will be working with the federal government on that waiver, really thinking through how we can provide more community-based care so that we can really think about our long-term stays in IMDs, and the kind of the services that are needed, such as community health workers on the specialty mental health side, supportive employment, rent and transitional housing, and how we build out the community-based system to support individuals who have severe mental illnesses. There's a lot. I know I went through that pretty quickly, but there's a lot going on at DHCS with regard to behavioral health. Very exciting, but again, some patience and grace because this takes time, and really a thoughtful partnership with all of you here.
Yeah, so for us, you all know, we are an active purchaser and we are proud of it. And so our journey is about how can we use that lever, how can we use the process of negotiating with and setting standards for our health plans to drive healthcare in a positive direction, to improve not just access, but quality, equity, usability of our system, which is particularly important in navigating our behavioral health system. And so we are constantly thinking about what can we put in our contracts that are really going to move the needle on behavioral health in a positive direction. And just to highlight some of the things that we've been integrating over time into the contracts, it's looking at integration of behavioral health and primary care. It's making sure, particularly during the pandemic, that our enrollees have access to the behavioral health services they need via telemedicine, right? It is holding health plans accountable to quality measures in the behavioral health space, in addition to other areas. And we have a huge new set of initiatives around improving quality and equity that we'll talk more about later, that we are including behavioral health and also looking to build out how we are including behavioral health in the future. For this year, we have proposed, they haven't been finalized yet, but new standards around how our health plans will hold third parties that administer their behavioral health benefits accountable. And this will also be a theme of some things we're going to talk about, but those same standards are in the DHCS contracts and in the CalPERS contracts, right? And so just an overlay of that is, yes, we're using our levers for our population to drive positive change in behavioral health, but we also want to be moving forward as a system and collectively signaling and incentivizing the system across California to be moving in the direction that we all know is a priority, and we all know behavioral health is an area that we need to collectively do better. The other thing that I would say is, I am really interested in how we can use our platform as a communicator, as an entity that is talking about the value and the importance of healthcare, to be a positive voice in reducing what we know is continued stigma around behavioral health, in making it clear that when we're talking about coverage and the care that everybody should be getting, that it's your primary care, it's your preventive services, but it's also the behavioral health services, the mental health services, the substance use disorder services that you may need, that your family members may need. I think this year, for the first time, we held an open enrollment event focused on access to behavioral health services and the importance of us being a pathway for that access. And so I think that's another area where we will all be working collectively just to move the conversation and to move the narrative and to recognize that that stigma and those barriers still exist across our communities as well.
Great. It would be great to hear, as we look now ahead, 2023, 2024, beyond the issues that we've already talked about, what are the big priorities at Covered California and DHCS that really are going to focus on quality and equity moving ahead?
Sure. So this is an exciting one for us because this year in our contract, so for the plan year that just started, 2023, so it's already in place, we have really put in a high bar around improvement on quality, improvement on equity. And from the beginning, Cover California has said our mission is not just about coverage, it is about improving the quality of healthcare across the state. But this is really doubling down on that point, and I think such an important time to be doing that as we are turning that 10 years, as we are recognizing the incredible progress that we've made on coverage. We need to make sure that the coverage we have extended to so many is connecting them to the care that they need when they need it, and doing so in a way that is equitable. And so I've been practicing how to explain all of this in a quick, simple way, but to do my best here, our contracts really have two pieces to them. One is a bare minimum level for quality that our health plans are going to need to meet, and if they don't and if they can't improve over a monitoring period, they will be asked to leave Cover California until they can improve. That is a 25th percentile of a national benchmark. That should be achievable, and we believe it certainly is achievable by all of our health plans, but we also want to be aspirational. And so we have chosen currently 4 core measures that we are asking for a higher aspirational level of quality, a 66th percentile of national measurement, and that our health plans need to meet or will have to put money on the table if they're not able to improve and to meet that level that we want to see. And I just want to say 2 things about this. One is I think it's very easy when you're talking about quality measurement, even in healthcare, there's a lot of acronyms, right? The NCQA and the HEDIS and the NQF, like all the acronyms. At the end of the day, what we are talking about is more kids getting vaccinated and their lives being saved because they were vaccinated, lower A1C, lower rates of hypertension, higher rates of colorectal cancer screening. These are things that are going to save lives and improve equity if we can actually get that care delivered at a higher frequency for our population than in the past. And Cover California is so unique in that, yes, we cover over 1.7 million Californians, but we have covered over 5.4 million Californians in our 10 years. And so if we can use the time that we have someone, even if that time is only a year of their life, to make sure that they are getting those key services delivered, we have a real opportunity to make a difference. And the other thing that is very exciting about this is we, again, are not doing it alone, that the measures that we have chosen and the incentives that we are putting into place are highly aligned with the ones that Medi-Cal is using in their core equity-centered measure set. And then CalPERS is also moving in the direction of the same measures and the same incentive set that we have. And just to put a number behind that, the three of us collectively, the three payers there, cover 42% of California, right? And so when you talk about alignment and the opportunity of alignment to really move the needle in healthcare, we're going to see if we can do that because we have the market power to move those needles, and we're going to be trying to do that together.
I want to start with something that just happened, the approval by the federal government of our Justice Involved initiative. And I really think of this as one of our key equity tools in the Medi-Cal space. As you may know, we just got approval 2 weeks ago, but really this is the ability for the Medi-Cal program to provide services 90 days prior to a person being released from prison, jails, or juvenile detention centers. Previously, there was, I'm going to quote, inmate exclusion, and so Medi-Cal couldn't, or Medicaid funds couldn't be used for some of these services. Really providing the opportunity to go in to provide these services, ensure smooth transition of care as a person is released. Really, as we learned through the whole person care pilots, huge opportunities for health improvements, huge opportunities for a reduction in recidivism, and so really excited about this opportunity to use this as one of our huge equity tools in the Medi-Cal space. Also want to touch about our 2024 contract with our Medi-Cal managed care plans. As you may know, January 1, 2024, about 99% of our Medi-Cal members will be in managed care. And so we are really doubling down with our relationship with our plan partners. They are our huge implementers and really setting expectations with regard to accountability, transparency, and quality and equity. I think about how plans really, we're looking at them to be the thread in our communities, to have relationships with child welfare systems, with continuums of care, with public safety, probation, all of the different programs and services that are there to help support and wrap around a person so that it's not just the health care that's getting delivered, but it's all of the services and supports that need to be coordinated to really meet our members where they need to be met. And so really thinking about our 2024 contract is this huge transformational opportunity to think about how we deliver services and what it takes to deliver services. So very excited about, I think that's going to be one of the huge things we're working through 2023 to get ready for, but a really big opportunity for the Medi-Cal program with regard to our services.
Lots to look forward to in the next 2 years. My last question, and then we'll open it up to a few questions from the audience. Maybe it would be helpful for all of us to understand how DHCS and Covered California work together. How do you collaborate? We heard a great example from Jessica about quality standards. How else do you all work together as a united force?
Right. I will think about the contract, our managed care contract. I know we worked very closely in terms of primary care and the definition of primary care and utilization, really trying to set some targets for what we expect from our plans in terms of what is your primary care spend, what do we expect it to be, and really thinking about how we push kind of up in the prevention lens of how we get more utilization on that front. So I think our teams work together to kind of, the more alignment we have, the more we can move the systems and kind of the entire healthcare delivery system together. I think the better we are in moving the mark.
Yeah, and I think we are, hopefully you've heard it today come through, right? Like really committed to working together, to having shared priorities and moving in the same direction because we know together we can move our healthcare system in the same direction. I think that occurs at this very macro, right, incentive setting perspective, and I think our quality work is a great example. Our primary care work is a great example of how we are really working to move the needle, but then it's also at this very granular level of an individual Californian who may be moving from one program to the other. And as we look forward to the redeterminations process starting, and we talked about this as well, our partnership in supporting consumers through that process from a real on-the-ground infrastructure coordinated perspective is also there. So it's really at that macro level, but it's also at this very consumer-centered micro level at the same time.
Great. Okay, thank you both. This was great. I'm going to stand up so I can see over the spotlights. If you have a question that you'd like to ask Jessica And Michelle, if you could come up to the microphone, which I believe is in the middle of the room back there. Oh, it's right here. Okay, if you could. Oh, you've got the first question. Great. Thank you. Could you introduce yourself and if you're affiliated with an organization?
Yes, I'm Sunita Sarabji with Ethnic Media Services, and we've talked a lot about coverage. I wanted to ask you both about utilization. You may have a $0 premium, but you're probably going to have a $25 copay, a $6,000 premium to meet, which can be daunting for families, low-income families. How are you addressing the cost of copays and premiums?
Yeah, so I think that question's for me because you don't have those, right?
Go for it, Jessica.
But I have a comment, though.
Okay, good, great. So I think incredibly important for all of us to recognize affordability isn't just about the monthly premium. It's about cost sharing. It's about the cost of care at point of service. And there is an ongoing conversation about whether that's something California wants to invest further in. I do think, this is something we've been focused on for a long time at Covered California. One of the key strategies that we use is our standard patient-centered plan designs that we have had since the beginning. So we really standardize how the benefits are structured across the different meta levels, including for those that are receiving a benefit we do offer to lower the cost sharing for our consumers. And we've really been able to prioritize and achieve moving critical services outside of the deductible. So your primary care, really all of your outpatient services that on the ground for receiving care is moving the needle. Another, I think, underappreciated benefit of the American Rescue Plan enhancing our premium subsidies is we've also seen a real migration of people into more generous, higher meta-level plans, right? So as their premiums are more affordable, they're able to say, well, I don't have to sacrifice and go to that bronze plan anymore. I can go to silver. We've also had really successful pilots automatically moving people who are paying $0 for bronze who can now pay $0 for silver, and seen some incredible results from things like that. We've seen also a big increase in dental coverage take-up, another example of how lowering the cost of premiums is letting people bring other care within reach. But I think as we move forward, particularly as we see whether the American Rescue Plan is here to stay, because we have it through 2025, but 2025 is really close to everyone. So we need to be focused on that we're continuing to study, to understand, to see the impact, because at the end of the day, we do still have plans that have high deductibles, and we need to understand what that means for the consumers that are enrolled in them and what that means for their ability to seek the care that they really need.
I just wanted to comment on underutilization in the Medi-Cal program. One of the core pieces of our comprehensive quality strategy is our population health management system and kind of strategy, where we do plan to use the data to identify where there is underutilizations, to try to think about how we can design interventions to reach those various populations to really ensure that they get the care that they need. Often care is, reactive, an ER visit or, some kind of injury, but really how do we use the data we have to build out where we think there are gaps in services or where we think that there are different interventions that might need to be developed. So it's a key piece of our quality strategy.
Great. Thank you for that question. Right on point. We've got another question. Please introduce yourself.
Hi, my name's Vanessa Ignacio. The microphone seems very echoey, excuse me. I've been a health insurance agent with Covered California and as well as Medi-Cal and enrollments from the very beginning. In fact, I was certified in late September of 2013. So I've been there all along. I live in rural Mendocino County, which is in Jim Woods territory. So, of course, I enroll many into Medi-Cal on Covered California because, of course, there are very few businesses that offer coverage. And when we talk about the Medi-Cal unwinding, I have a real frustration. And do often enroll people in Medi-Cal through Covered California, but there's a real barrier to their renewals. We have the Medi-Cal unwinding, and as Jessica accurately pointed out, 95% of Californians are within 15 minutes of an enroller, and yet we're not able to be used by the Medi-Cal system to unwind and do the renewal. and I understand there's very complex, and this was built before we actually used it, so the SAWS system overrides the CalHERS, and I understand that we're not going to fix that. But if in all of the training for the social workers and the social services employees who are going to be processing these renewals would just be trained to check on the Covered California application about updated addresses and income and even proof of income before they attempt to hunt down someone, it would make the job of unwinding so much easier. Because Covered California has done a phenomenal job at making it really easy for someone to access someone who can enroll them. And Medi-Cal can use this infrastructure that's already in place to make such a huge difference. Thank you.
Appreciate the feedback. Thank you.
Time for one more question before we end. Olivia looks like she's bringing the mic over to someone. Please introduce yourself.
Hi, it's Patricia
Oh,
Tanqueray.
Patricia, hi. It's hard to see from up here with the
I
spotlight.
know, the light is in the eyes. I'm the former CEO of Contra Costa Health Plan and now a consultant after I retired with HMA. I think all of your comments were very good. I want to make a comment and then a question. Part of what I think is going to really help, since we all know how much children have suffered during the pandemic because of lack of ability to have well-child visits, etc. Telemedicine is a good thing. It doesn't solve everything. So the fact that we read from DHCS that children will not be terminated until the end of the year is making many of the medical groups, who work with children much more comfortable with children who are in, needing a lot of care. 2 weeks ago, there was an article that said the state of Oregon and I believe the state of Washington had decided they were going to extend 3 years worth of not having to go through reauthorization for children. Is that something California is talking about? Do you think it's possible?
So I'm not tracking what Oregon and, did you say Washington?
Yeah.
Yeah, so we'll have to take that back.
Okay. Take a look at it. It would be very enactful with the same reason they are choosing to do that, so that children's preventive care, child care scores would go up and they wouldn't cycle off and then have months and months of no coverage during a confusion time. It was pretty exciting. It was only 2 weeks ago I saw it.
Patricia.
Thank you.
Kristen, you have a question? Yeah, let's get you a mic. Or come over here and I'll give you this mic. Yeah, but you need a mic.
Here, I got it.
Oh, here comes Olivia. Kristen, introduce yourself.
Hi, Kristen Golden Tester with the Children's Partnership. Just in response to that, we did just pass and got enacted in the past budget. California is going to be offering multi-year continuous coverage to young children up to the age of 5. So we are going to be doing what both Washington and Oregon already had it federally approved, and Washington and New Hampshire have a waiver in, and we're really hoping that California will start that implementation, because right now on the books it's not to begin to 2025, but we want it to begin as soon as possible so that we don't have kids with the gap coming out of the unwinding. So we really want to get that waiver into to Dan over there.
Great. Thank you. Okay, we are so lucky in this state to have these two women leading these two important organizations. Let's have a big thanks to Michelle Boss and Jessica Altman for their incredible work. Thank you both.
Even worse from this position than they are from the podium. But it is nevertheless my very great pleasure to introduce our final speaker of the day. We want to welcome Daniel Tsai, the Deputy Administrator and Director of the Centers for Medicaid and CHIP Services at the Center for Medicare and Medicaid Services, or CMS. He leads the center in addressing disparities and advancing health equity to serve the needs of individuals and families who rely on these essential programs. Before joining CMS, Dan was the Assistant Secretary for Mass Health and Medicaid Director for the Commonwealth of Massachusetts, serving for 6 years. His tenure focused on building a robust and sustainable Medicaid program to ensure equitable coverage and improve health care delivery for 2 million individuals and families. I'll let you give other context for your work there, which I know was important, involving value-based payments and other quality improvement efforts. But really, we are delighted to have you with us here in California today and appreciate you making time for this group.
Thank you. It's very hard to see anybody here. So I think I'm looking forward just to dialogue and Q&A. And for Oregon, yes, we approved 0 to 6 years of continuous eligibility. So it sounds like. So I thought I would give a few just remarks on where, from the federal standpoint and this administration, how we think about Medicaid and Medicaid priorities and coverage. And then I certainly want to touch a little bit on redeterminations and unwinding, and then just to see what other thoughts folks have. But it's nice to hear, Michelle, this side, just how you talk about your programs, because we spend every winter holiday slaving over California 1115 demonstrations somehow. Christmas Eve. So it's, but it's helpful to hear how you all talk about it to you. It is consistent with what you say to us. That is good. And it's exciting to hear how Jessica covered California, and you all are thinking holistically together as purchasers, so that's great. Medicaid now, we are at 91 million people strong. We're not going to stay there for the redetermination piece, which we're all very focused on. But that's a really incredible number to think about what Medicaid has been relative to coverage during the pandemic and for how many folks are covered. And I always quiz people, do you know how many kids in the country we cover? Does anyone know? Or what percent of kids? Yeah, this is a knowledgeable crowd. 51% of kids in the country. But if you tell most folks that 51% of kids, 1 in 2 kids in the country, are covered, 42% of births, most people are highly surprised by that. And so we have a really powerful, important tool. And it's really exciting to see what we can do. So some of the priorities we've highlighted from an administration standpoint for Medicaid: coverage and access, health equity, and innovation in whole person care. And that covers a big gamut of things. We could talk for a long time about that. Medicaid expansion, thinking about, in the coverage realm, thinking about, Oregon just came up, how do we reduce some of the churn that happens with the Medicaid population for folks that are still eligible. The ACA brought on 12-month renewals for a bunch of the population, the MAGI population. I think this crowd will be familiar with all those terms. And so now over 90% of people, adults and kids, maintain coverage for 12 months. But a bunch of people lose coverage at 12 months, and over the next 2, 3, 4, 5 months, they come back to coverage. And that's a challenge for population health, for coverage, for a whole bunch of reasons. So that's why we're excited and work really hard to kind of think about how to justify an 1115 demonstration in a place like Oregon and now Washington, and it sounds like Michelle, for coverage for kids continuously from 0 to 6 years, or for adults, certain adult populations for 24 months. And some of the rulemaking and approaches we're taking at the federal level really seek to help reduce the risk of folks losing coverage for procedural reasons, not because they're not eligible. And so coverage is a really big piece, and obviously, we could talk a lot about Medicaid expansion. And then there's also how we think about access. And a core part of access that we've focused on is really thinking about core access to primary care, behavioral health services, OBGYN services. And if you look at the data, there are there's both rich access in places and incredibly challenging access. And it's hard to think about topics like health equity or population health or improving the health of a population without addressing some of those core access pieces. And so a lot of what we spend time doing is not only individually working with states on what does it mean, are rates sufficient, how do we think about delivery system structure, how do you think about your behavioral health services, but also to think about how we define through upcoming regulations a new way of thinking about the floor for the Medicaid program, defining what access looks like, and particularly in managed care, what does timeliness of access look like? That's not just time and distance spreadsheets that don't really say much. What percent of the time can you actually access care within X days? And then there's a lot around conscious of time. Like, there's a lot going on in the Medicaid program. I like Medicaid. I love Medicaid. I hope you all do too. We could talk for a long time about it. I think it's one of the coolest things that exists. So, and we want to operate as an administration as a really proactive payer purchaser, thinking about how to move the Medicaid program across the country. In the State of the Union, the fact sheet that went up today and also last year, you'll see Medicaid, you'll see behavioral health, you'll see crisis, you'll see school-based Medicaid, you'll see justice-involved 1115 demonstrations highlighted. This is an administration that cares a lot about Medicaid. I'm going to spend just a minute on unwinding and redeterminations and then just dialogue from there. It sounds like we need to hire the person that had a comment about how to think about all this stuff. But I know California, I know states, I know we have put unprecedented effort into preparing for unwinding and for redeterminations. It's going to be bumpy. Our priority, policy and operationally, is to make sure that we do everything possible to keep people covered. If you're eligible, we want to keep people enrolled in Medicaid, and we want to reduce the risk of folks losing coverage procedurally because they didn't get a piece of paper in the mail. And if someone's eligible for Covered California or Marketplace coverage, we want to help them get there. And so I'm curious to hear how you all think about that here, but that is a huge priority. The omnibus and legislation gives us some tools to help really push our state system forward and thinking about eligibility and redeterminations and such. So I'm going to stop there and see where you want to go.
Thank you. Well, I'm going to flip the order a little bit of some of the questions we talked about in advance, and I wonder if you could just step back and talk about what you see as sort of the areas of responsibility and maybe the division of labor between the federal, state, and local partners in moving the healthcare system in any way you want to take it, but I'm thinking probably in particular in the Medicaid program. Because obviously everybody has different tools at their disposal, everybody wants to work together, everybody's got different strengths and maybe limitations.
I can tell you, I don't go to sleep at night worried about my call center wait time or whether claims will be processed now that I'm not running a state Medicaid program. So there's a clear delineation of responsibilities between the federal and state level. But I think of it as a partnership. And I wish we all, sitting in a different chair, it gives you a very different perspective on what you knew and vice versa around that. So I think we understand and are hoping that in almost all cases, states, regardless of where folks are on the spectrum of whatever, are really actively leaning in to try to figure out the tough work on the ground for redeterminations, for renewals, all of that. And at the same time, there's always more opportunity. Very few states are completely compliant with every regulatory requirement we have. Surprise, surprise.
Shock.
And that means there's opportunities to help people move forward in adopting and making sure folks are thinking about how to outreach, how to renew folks, how to simplify the system in ways that have the effect of keeping people covered. And so we do a dance where we partner with states, we partner with California, we partner with others to understand where folks are practically, and we have oversight responsibilities. And both those things are in tension. States have a lot of hard work on the ground operationally, from staffing to all the work, and I remember that.
Yes. So there are a lot of CalAIM priorities, and I know you're well familiar with all the work afoot here, including the work to better connect the justice-involved population that really rely on excellent coordination across many different sectors. And perhaps from your experience in Massachusetts, but perhaps also from your experience at the federal level, what do you see as some of the ingredients for success, or are there success stories you might share with us that would be relevant as we roll out what is acknowledged by everyone as a very complicated but super important effort to expand beyond the traditional healthcare system.
So I have to applaud California as much as I joke about how it sends us to the federal level trying to rethink, how you conceive of Medicaid. I have to applaud California and a range of other states for really wanting to think holistically about person-centered care and what that means. And so we want to support that. We as an administration are excited about that. We spent a lot of time breaking ground this summer to think about the role of Medicaid with the right guardrails and covering things like housing and nutritional supports, with really recognition that from an equity standpoint, it's hard to address some of those systemic factors that lead to a whole range of health equity disparities without addressing a broader range of the social determinants or health-related social needs, if you will. And so we think there's a really clear role for that, and our work with California helped pave the model along then with Massachusetts, Arizona, Arkansas, and Oregon. I think the complication is then, as complicated programs, when you roll it out, if folks can't understand what it means or frontline providers can't see how things fit together, it's hard. And California is a large state, so I don't envy the difficulty of the work at all different levels of trying to figure things out. But I think things do have to be simple, and I think at the end of the day, as well, folks need to know who's on first for what. And if you have a bunch of different wraparound services, like there's potential for a lot of cooks in the kitchen, and sometimes those cooks in the kitchen complicate things for an individual or an enrollee or a consumer. But those are all the realities of trying to move a delivery system in a very different way.
Yeah, thank you. So we are going to have time, I think, for a couple of questions. So if anybody has one, raise your hand and we'll find a mic for you. I wonder if you could elaborate a little bit on the overlay of all your work with advancing equity. And I know that's a big concern for you, and it's an enormous question, so take it in whatever direction that you like. But clearly that's an increasing concern for, I think, all of us in a state as diverse as California. There are a million ways to think about how we can do better and for whom. But I'd love your thoughts on that broadly.
And I appreciate, I think, in our national dialogue, how much folks are focused on equity at this point, and that's really exciting. I think of it at multiple levels. We think of it at multiple levels. There are very first-order questions like the existence of the Medicaid program, being able to have coverage, Medicaid expansion, reducing barriers to enrollment and renewals, having culturally competent ways of supporting and engaging that. None of the other things around health, like if you don't have coverage, you're not going to have much of a cry relative to trying to address some of the disparities in health outcomes. So that's why we put so much focus on that. And then part and parcel of that, why we emphasize access so much, is if you can't access your primary care doc or behavioral health clinician in a timely way, no amount of super snazzy care coordination, like you're care coordinating nothing. And in the Medicaid program, we know we have access is sometimes more difficult than we would like it to be. And so those things are really important. But there are also more unique pieces, like you heard from Michelle around our 1115 demonstrations for justice-involved populations, our work with Massachusetts and their 1115 on equity and coverage incentives to really close health disparities. And us wanting to track more data to measure disparities and then to actually make progress around closing it. So I think, because I love the Medicaid program, I hope if you're in this room you kind of do too, the existence of and everything we think about policy-wise for Medicaid is all about equity, and it really annoys me when you see issues of parity, whether about the types of providers people have access to or the systems. Care should look like for our Medicaid enrollees the way we would expect it to look for ourselves and anyone that we know and love.
Thank you. Do we have a question? It looks like we may not. It might be impossible for me to tell if we did.
That means you're all incredibly satisfied with what we do at the federal level.
All right, we have a question up in front. And again, if others have questions, raise your hand high, because this is a big room and the light is impairing my...
I have a broad question. Was this the right time to end the public health emergency, given that we're still dealing with subvariants? We don't know how this is going to go at this point.
I'll leave that answer to the scientists, and I'll just say, given we know the timing, and some of it for the redeterminations was statutory through Congress and the omnibus, the work ahead of us is to do everything possible to make sure we keep people covered.
Yeah, that's a little bit off your domain, but a really important question. And the question about, I think, the redeterminations is similarly, it's linked or was linked to the public health emergency, but the timing is similarly a moving target on some level, but perhaps in some ways just as well to get on with it since we know it is coming. Do we have other questions? I see one. Thank you. And Kim, if you could let us know who you are.
Hi, Dan. Kim Lewis from the National Health Law Program. How are you? I wondered if you want to talk a little bit about how CMS plans to use data in the unrolling. I know that's kind of a big question, and I know that the data may not be in real time available to CMS, but I'm wondering if you've thought more about how that data can be used as a way to sort of see how states are doing and to sort of hold states accountable for what you might expect to see in terms of the unwinding process.
Yeah, so it's a really critical part on multiple levels. There's both things that, in the end result, when we will be reporting out a range of information. A lot of this is specified in statute as well, of kind of everything from each state, what the procedural terminations were, to call center wait times and things of that sort, all outlined in statute as part of the set of things that we have to report out on a monthly basis, transparently. But more importantly, when we think about our relationship and how we manage and work with states and make sure that folks have every chance of maintaining coverage, we're looking a lot of those metrics as early as they come in, even when the data is not clean and they're not all ready to be released. And as important is the cross-cutting group we have internally, that's just not just Medicaid, but a range of folks across CMS and others, looking at, we call it the early warning report, that looks at everything from call center wait times to application processing times to things of that sort, that give you a sense if something is an issue, and that allows us to engage in good faith with the state or the states where you see some of the data starting to spike, to really understand what's happening and are there issues we need to get ahead of and address before you get to the point where the terminations have actually happened. If call center wait times are going up a ton, you kind of know something is happening and stuff is going to bubble downstream. So that is very much part of the internal workflow that we have established, and we're engaged with, 190 of our state best friends every single Friday in partnership and collaboration to try to manage the redetermination process.
Thank you, and thanks for the question. And maybe one more question from the audience.
Hi. Ooh, that was loud. Lisa Chanson with Transform Health. Thank you for taking my question. Along the similar lines of Kim's question around data, I wanted to ask the question, right now, so many states are looking at social determinants of health. We see a wellspring of different approaches across the nation. States are looking at a number of social determinants ranging from housing, food insecurity, employment, education levels, interpersonal violence. Arizona was approved for tribal healing arts. There's a wellspring of great ideas. And I was wondering, as the data comes in and we begin to see the differential outcomes, what type of data can we expect to come out of CMS to help inform future policy?
That's a good question. There's everything we wish we could go analyze, and then there's what we probably will be able to do. I would say CMS over the past number of years has taken a lot more focus on evaluation and monitoring and working with states on the rigor and structure of that. I remember discussions when I was in Massachusetts from CMS pushing on the exact evaluation structure and things of that sort. I was like, why are you asking me to do this right now? I have a program to run. But the questions make sense. And we are putting substantial effort behind that and emphasizing the importance of that, particularly for things that we think really could move the needle but really need to demonstrate impact.
Thank you. And thanks for the question, Lisa. So I think we're going to come to an end here. I want to thank you again, and I want to note what maybe is obvious, but maybe not to some of our participants here, that having a federal partner that is thoughtful, engaged, shows up, and I mean here now, but also I'm sure in all the day-to-day work that our Department of Healthcare Services engaged with, is hugely important. And yes, California is big, but the federal government has access, responsibilities, tools, and resources that are super important for how well we can achieve our goals. So thank you so much for being here. And thank you to the folks that are working with you in D.C., but also here in the state to make that partnership a reality.
Well, thank you all. Thanks for your advocacy and your energy, and I think you all love the Medicaid program, so you're all good in my book. Thanks.
Right, let's see if this mic works now, too. So we've come to the end of the day, and thank you all for being with us through what was, I think, a really engaging and valuable set of conversations. Special thank you to all our speakers and conference sponsors. Don't pack your bags yet. There's still a raffle announcement coming, but one couple of minutes. I just want to very quickly reflect on what I heard and saw today, which was a combination of sort of the traditional ITUP conversations with state leaders and about the topics that we have cared so long about around coverage and access to care and affordability, but also new topics around telehealth and youth behavioral health issues and just a range, workforce, which has always been with us but has never been more salient than it is today. And I just really appreciate everybody who came in, participated, put together those conversations. I have to just again acknowledge the fantastic ITUP staff that put this event together, and I want to ask you to join me in doing that. So much work behind the scenes to make this, again, a really first-class conference for all of us and an opportunity for us all to be together and engage with each other in ways that we have not for far too long. I want to quickly nudge you about evaluations. Every time you've ever been to ITUP, we ask you to please give us evaluation feedback. That really does inform staff and board in our planning for the year. It's all accessible through the app. Please, please, please. I want to make one last announcement on ITUP's behalf, which is to introduce the person who will succeed me as the chair of the ITUP Board of Directors. Not quite yet, but again, very soon, Sunita Mutha will be our new chair, and I wanted to give her just a moment to greet you as well.
Thanks, Marian. What can I say? How often do you get to do something that is meaningful and really, really important? So I'm thrilled to have this opportunity. I have an incredible set of colleagues on the board. For those of you that think you love the organization, keep in mind, board service is an option, as we'll be thinking about that in the future. What I really am excited about most, and several of you have called us out, is Crispine. We are thrilled to have you join the organization, to lead the organization, and just excited to see how we continue to stay relevant and to do what, for me personally, this meeting has done the last day and a half, which is to touch on things that matter, that are actually actionable, and to celebrate the progress that actually has been made and the investment. So super exciting time. Excited to see what it looks like with new leadership, and thank you, Marian.
Thank you, Sunita. Yeah, I will just quote Dan in the room I was in where he was speaking to students very kindly about moving as fast as you can without breaking it, which is advice he said he got early in his career. And I think a lot of us have that great urgency to do more and want to appreciate all we've learned and know about the complexity of the healthcare system and the centrality of the needs of consumers that mean we need to move with great determination, but not without respect for what might go wrong as well. Okay, I know the only reason you're still in the room is who won. So we hope that everybody whose name was pulled is here so that I don't have to read this long list, but I have several names. Victoria Mesquita. Are you here? Yay, Victoria is the raffle winner. All right. So thank you, one and all, for being here. We appreciate you all. We appreciate your support of ITUP. We want your feedback, and we look forward to connecting with you through the year in regional work groups, through our publications, and again in a year or so in a venue like this. Thank you, one and all.